That is the after mapping of axilla, radiation, or surgery. This trial was proposed in 1998. Finally, it was approved uh, to be launched in 2000, and they started collecting data from February 2001 with amendments. Final amendment was in 2008, and the article was published in the final state in November 2014 in Lancet Oncology. Uh, and when we discuss breast cancer, it is very important that we should know why axilla is so much emphasized in the management of breast cancer. From the era of when the breast cancer was considered a locoregional disease, and it was treated in very aggressive locoregional treatment methods to the era in which it is considered a systemic and as well as a locoregional disease. So this has modified our treatment plans and the management of axilla as well. And from very heroic health type of excisions, we have come to sentinel lymph node biopsy. The concept of sentinel lymph node biopsy first started in late 80s and early 90s, and we came with the first series of sentinel lymph node biopsy accuracy in 1994. It was followed by first randomized controlled trial publication in 2003. After this, we were with some landmark studies in the management of sentinel lymph node biopsy and its validity in comparison to axillary lymph node dissection. And these studies are ACO-SOGC11 trial and International Breast Cancer Surgery Group 20 not one trial. And these trials address the patient population with early breast cancer, that is T1, T2, and these patients has no palpable axillary lymph nodes, and they were offered breast conservation surgery with whole breast irradiation, and the groups which has 1 to 2 lymph node positive, so they were not candidates for axillary treatment any further. And they were supported with adjuvant systemic therapy, that was new chemo or the hormonal therapy. And they concluded that the overall survival at 10 years is comparable in both groups, those who were only limited to sentinel lymph node biopsy and those who were offered axillary lymph node dissection. So the hypothesis is that when the study was published in 2001, the lymph node dissection was the standard treatment in patients who have sentinel lymph node biopsy positive. But the lymph node dissection has its own sequelae. It requires theater bookings, it required more surgical resources, and there are sequelae of surgery. The sequelae of every surgery, like infection, hematoma, seroma formation, and sequelae specific to this surgery, that is lymphedema and restricted shoulder mobility. So the hypothesis was established that can we replace this group of patients with radiation? And is this comparable? So the European Organization for the Research and Treatment of Cancer sponsored this study, and they designed the study. It was a randomized 2-arm, multi-center, open-label, non-inferiority phase 3 trial. And for those early students, I want to tell that this shows the power of the study. Randomization is always good if it is non-biased, and multicentricity is good because one surgeon and one institute can also have some bias. Open label in surgical randomization, it is not possible that we keep everyone blind. Patient has to know that what he or she is going through, and you cannot blind a surgeon for what surgery that surgeon is going to perform. Non-inferiority means that this trial is going to establish that is radiation therapy is same as our previous standard, that is axillary lymph node dissection or not. Phase 3 trial that it is going to be change our treatment guidelines. And we already have some other trials in its sequelae. Uh, this trial started in 9 European countries at 34 centers, and there were 4,823 patients enrolled in this trial. Among them, 7 patients they didn't give the consent, and they left with 2,402 patients for axillary lymph node clearance group and 2,404 patients for axillary radiotherapy group. Like in every study, there are some inclusion criteria and some exclusion criteria. Here, all the women without any age limit were included with invasive breast cancer of T1 or T2 stage. And initially, the tumor size was restricted to 3 centimeter. And as in the previous Z11 trial and other trials, there should not be any palpable axillary lymph adenopathy. Uh, Only unifocal tumors were initially enrolled. Um, the patients for both mastectomy and breast conservation therapy were enrolled in this, although the mastectomy patients were only 17% of the total patient population. The inclusion criteria was revised in 2008 as there was change in the practice guidelines as well. So the tumors of up to 5 centimeter were included. Multifocality was no longer an exclusion criteria, and they started including it in the patient population. And sentinel lymph node with only isolated tumors, they were not considered as the positive ones. The exclusion criteria was the any previous history of malignancy, patient who has been given new adjuvant chemotherapy, previously treated axilla for any other reason, or malignancy that either it was surgical or the radiotherapy. And again, I will say the multifocality that was changed in 2008. It is very important in a randomized control trial that you mask the patient population. So it was done at the EORTC headquarters, and they established at 1-to-1 ratio for the axillary dissection group and for the radiation group. It was to prevent the selection bias at the centers, and it was also that when the sentinel lymph node dissection was done, so at the same time, it can be proceeded to the definitive surgery. And so if you look at this closely, this shows that why it was so important. Clinically, they included the patient with the breast cancer, the initial stages, and then at that point, randomization was done. That which patient will go to axillary lymph node dissection group and which patient will go to axillary radiation group. After that, sentinel lymph node biopsy has been performed, and those who were negative, they were split into a separate line, and those who had a sentinel lymph node positive, they were randomized, and they were all previously randomized, but they were separated into 2 groups as their previous allocation into radiation therapy and the dissection groups. All the centers has to fulfill the surgical quality control criteria, and they demanded the surgeons to perform sentinel lymph node biopsy virtual technique, and if not possible, so radioactive technique is preferred. Dissection was up to at least level 1 and 2 with at least 10 axillary lymph nodes to be excised. And the radiation criteria was at all 3 levels plus middle part of the supraclavicular fossa to be excised, and dose was 25 fractions of 2 gray. In every non-inferiority trial, they have to set an endpoint, that is a criteria to against which the proposed treatment or proposed plan is tested. So the primary endpoint was 5-year axillary recurrence. That was 4% in the case of axillary radiotherapy group, and not more than 2% in the axillary lymph node dissection group. This recurrence was only in ipsilateral axilla, infraclavicular fossa, or interpectoral area. Supraclavicular node were considered as distant metastasis, and whenever there was a recurrence, it has to be confirmed by cytology or histopathology. Secondary endpoints in this case were axillary recurrence, pre-survival, disease-free survival, overall survival, shoulder mobility, lymphedema, and quality of life. From these slides, I will quickly go through because the literature was provided and I hope you all have read it well. Median follow-up was 4.5 years. Lymphedema was, patients were checked for lymphedema at 1, 3, and 5 years. Quality of life was checked as per questionnaires. So if we look closely at how randomization was done, the 4,823 patients, and finally they were left with 744 patients in the axillary surgery group and 681 patients in the radiotherapy unit. In this statistical analysis, only sentinel lymph node positive group was acquired, and only and those lymph nodes were counted which were sentinel. Clinically suspicious or intraoperatively suspicious nodes were omitted in this data. Not all patients underwent ultrasonography. In this patient, only 859 with all the positive sentinel lymph node patients went through pre-operative ultrasonography in this patient population. So, in the you all can hear me? Hello?
Yes, we can hear you.
Yes, we can.
Yeah.
I'm sorry, there was some interruption. So in axillary lymph node group, there were 220 patients among the 672 patients who were proceeded with the axillary lymph node dissection group, and among them 52%, 8% patient has 4 or more additional lymph nodes who were again given to the radiation group as well. But in the data, they were put in the group with intention to treat in the primary randomization. Recurrence happened in 4 out of 744 patients, and the 5-year axillary recurrence was 0.43%. In the radiation group, it was 7 patients among 681 patients, and isolated only the axillary recurrence was there in patients without any other distal metastasis were 2 of the 7 patients. And 5-year axillary recurrence was 1.19%. So these results are quite comparable. While another limb in which the sentinel node was negative, only 0.73 patients go through had any type of axillary recurrence. So these results were what the trial was intended for. It is very important to treat patients according to their disease. Custom-made treatment. So it was not that we assigned a patient to a group and we will stick to it. So where they required, dual treatment was offered to the patient. So 41 patients in axillary lymph node group and 12 patients in the radiation group received both limbs of the treatment. Disease-free survival at 5 years is also comparable in both groups. In axillary lymph node dissection, it is 86.9, and in radiation therapy, it was 82.7. There were 71 deaths in axillary lymph node dissection group and 76 in the radiation therapy group. And deaths due to breast cancer were 53 in axillary lymph node dissection group and 54 in the radiation group. So this is a graphical representation of this, and we can see that with only initially it's same and slightly higher axillary lymph node dissection group, but it is again comparable. Overall survival at 5 years in axillary lymph node dissection group is 93%, and in radiation therapy group it is 92.5%. Axillary recurrence-free survival was same as overall survival, it's not reported in the data. And this again is the graph that is quite comparable in both treatment limbs. These are the baselines and treatment characteristics and all the patient characteristics. I will quickly go through these slides. We all have access to this online. Here I will stop for a while. If you see and at one glance you will see that there is marked difference in the lymphedema percentages in patients among axillary lymph node dissection versus those who go through axillary radiotherapy. At 1 year, 28% versus 15%. At 5 year, 23% versus 11%. So that is a marked difference, and its p-value is also important. So this trial interpreted that axillary lymph node dissection and axillary radiotherapy after a positive sentinel node provides excellent and comparable results in primary or operable breast cancer with no clinical lymphadenopathy. And it also concludes that axillary radiotherapy results in significantly less morbidity. If we discuss this trial, so again, the same thing, axillary lymph node management is important. It has prognostic information, it provides local visual control, and overall survival as well. Before this trial, we have some other trials, but no trial randomizes the axillary lymph node dissection versus axillary radiotherapy in the setting of sentinel lymph node positivity. So this was first randomization of its type. And the thing that I find slightly off limiting in this, that this was based on sentinel lymph node positivity, but what is the credibility of sentinel lymph node positivity? From the literature review, we see that sensitivity of sentinel lymph node positivity is 89.6% to 96%, and false negative ratios are from 84% to 6%. So this limitation is there. But there are also literature reviews that show that recurrence in axilla after negative sentinel lymph node, when we don't offer any further treatments to the patient, is 0.3%. And when we offer the axillary lymph node dissection, that is 0.8 to 2.3% in a meta-analysis. These results are in accordance, on our trial, like AMAROS trial results are in accordance with the randomized controlled trials that has compared axillary lymph node dissection with in the setting of mastectomy. In NSABP not for trial, they had a 25-year follow-up between a modified radical mastectomy and mastectomy with radiation therapy of axilla. And they had comparable recurrence rates in both, that is 4%. And in a French trial with 15-year follow-up, early stage breast cancers were involved. They were offered breast conservation surgery and wide local excision with the breast irradiation. And axillary recurrence rate was 1 versus 3% in axillary radiotherapy group with the p-value of 0.04. But survival rates at 10 and 15 years were comparable. So why to face this when we have an option with the radiation therapy? This is a patient who has multiple hospital admissions, long treatments, lifelong precautions, because she has been treated with axillary lymph node dissection. You can see the cellulitis and all the edema over there. But again, before we launch to this conclusion, we see that how valid our trial is. I see that there is imbalance in the distribution of patients in both groups. I mean, 63 more patients in axillary lymph node dissection group. Although this randomization was central and done at the headquarters, so we can say that it is a chance bias. So these are the characteristics of both lymphs, and I'm going to emphasize it that we all see that the number of the sentinel lymph node removed in group 1, that is the dissection group, is 332 and 293 in the other group. And there is also slight variation in the rest of the numbers. It is also important in a randomized controlled trial that how compliant is a patient to the treatment. So some patients have both limbs of the treatment, and there is crossover of the patients, but the crossovers were put in the same group as they were put at the time of the randomization. So it was intention to treat type of analysis. It can somehow change the group statistics, but it's 46 and 68. So total number of crossover is still less significant. So the conclusion was that among axillary lymph node dissection and axillary recurrence, both provide good locoregional control in primary breast cancer. Both groups have comparable axillary recurrence rate and no significant difference between the groups in 5-year survival noted. But there is significant difference in the lymphedema group. Another thing, we start counseling our patients very early about the lymphedema. So in the quality of life performance, not many patients were concerned about their lymphedema options. And there is another thing that is called response shift in quality of life. The patients somehow slightly accept their lymphedema and they start and learn to live with it. So this is a thing that should be kept in mind. Shoulder mobility was slightly high in patients with dissection group, but not very significant as compared to the radiation group. Another thing that is questionable, that patients who were put in the radiation group, they were slightly overtreated. They were given the radiation not only to the level 1 and 2, but also to level 3 and the supraclavicular area. So we can question that in this treatment group, the number of the patients were overtreated for recurrence. Another thing, at that time, it was not very important to look at the luminal types of the breast cancer. It was not considered very important, but now it's a type of the, but now it is a significant part of the breast cancer management, and a significant luminal types can entirely change the patient treatment plan. So this trial, it lacks the hormonal status of the patient. It also does not comment on the lymphovascular invasion and extranodal extensions. And it also does not enter in the quality of life performance, the radiation specific morbidity of the patient, like burning and loss of skin elasticity and pigmentation. When we see a trial in some other population, we have to see how compliant we can be when we implement these things to our patient population. Our patient population usually 30 to 40% patient present in stage 2 or beyond. In our center, most of the patients are at T3 or T4, and they with palpable nodes positive in more than 60% patients. So less of our patient population with breast cancer is candidate for this trial. So we have to focus more on our screening program. Another thing is the availability of the radiation therapy. We have enlisted a patient to treatment according to this trial, and we have not followed the patient that when the radiation time is due. So let's suppose we have done surgery in January and patient got the 3D radiation time in September. So that is not going to help patient in any way. So the surgeon should be very careful in which setup they are, and when possibly the patient get time for the radiation therapy before implementing this trial in their practice. So my final conclusion is that both groups did better than their primary. They did much better than the established endpoints, that is 4% to the radiation therapy group and 2% in the axillary dissection group. So the primary endpoints are very low, but still it does not rule out the validity of this trial. It establishes that both limbs actually done better than they were proposed, and they've done almost equally better. Again, the lymphedema was slightly significantly better in the radiation therapy. And this study was limited to the patients with the upfront surgery. Again, the question is here, the patients who went through neoadjuvant chemotherapy, how would be the stance of axillary management in those patients? Now I will hand this over to Dr. Raza for further discussion. Thank you.
Thank you very much, Rabia. This was a very nice presentation. Thank you so much for such a nice overview of the. It's a big study, and you have done that in extensive detail and also in a limited number of minutes. So thank you very much. You have actually set a bar which we're very happy with in terms of the level of presentation for these journal clubs. Thank you so much for that, Rabia. I would now request our faculty, Dr. Huma Khan, Dr. Asad, Dr. Amjad, and Dr. Sana to kindly give your remarks regarding the critical appraisal of this article.
Dr. Huma, you want to go first?
Okay, I can start. So generally, okay, I think because it's like this is year 2022 and the study was published in 2014. So obviously now there is like an academic bias in a lot of minds because we have now known about a lot of other factors which has emerged. So if we put them aside and we just look at the study itself, there are two things which come to my mind, like if there's what are the good things and what are the bad things, and is it practice changing and is it applicable to our scenario, right? So the good things are right. Okay, so comparable results, survival, local regional recurrence, etc. Quality of life and lymphedema more or less is the same. My critique of the study is that like they changed the criteria in 2008 and then multifocal and the size became, up. Initially they had like a 3 centimeter and then they included up to 5 centimeter and included multifocal as well. The other thing is that they have like BCT and mastectomy both. And we know that when you do BCT, there is always a spillover radiation anyway. And in mastectomy, yes, you can say that either you give radiation or you don't give radiation. So there's no comparable sort of analysis of that I can see there. The other thing is that in some of the axillary lymph node dissection groups, they also added radiation. And that may explain more lymphedema in that group, because now we all know that if you give both, the chances of lymphedema are very high. So you have to choose between one and not both. That is the current sort of situation at the moment. And as Rabia said, the biology was not taken into account. So suspicious lymph nodes, they again excluded. And I think that that's an extremely important thing, because sometimes sentinel lymph nodes are not really, the sentinels, because the lymphatics block. And you have some other nodes which are also there, which may not stain or take up the radioactive dye, but they are also suspicious. And lastly, I think that there is like this over treatment, as Rabia said, with the XRT group. Like in axillary lymph node dissection, you usually go 1 to 2 level. But if you're going to give like up to level 3 or 4, you're going up to the supraclavicular fossa, then it's not a comparable treatment, right? And lastly, I don't know what you guys believe. I don't think that supraclavicular lymph node, either ipsilateral or contralateral, is systemic disease per se. I think it is prognostically important, because most of the times when you have a supraclav, usually there's metastases as well. So they go hand in hand. Rather than that it's systemic. Isolated supraclav is not systemic. I don't see it like that. I don't know how you guys see. So this is like roughly, and as for the practice changing thing, we have to consider like mastectomy versus BCT. That will be important, because in BCT there's always some radiation. And the other thing is the availability of linear accelerators. So if you don't have you have to see what is available and then plan your patient accordingly. Thank you.
Thank you, Dr. Huma. I fully agree with all the points highlighted by Dr. Huma. In this day and age, we are all aware that disease recurrence and patient's outcome depends more on the tumor biology rather than an isolated TNM stage. And like this study has not included the tumor biology at all. If if we ever think about doing this for our own patients, we do need to keep in mind about the triple negative disease, the HER2 positive, the aggressive variants, the need for systemic treatment prior to the surgery. All these things need to be taken into account. Another thing which this trial didn't talk about was the age of the patient. So in elderly patients, like we know that axilla, the management of axilla is being downstage now, and beyond 70 years of age, patients may not even be fit enough or qualified enough for a sentinel node biopsy if it's an early breast cancer with a good favorable biology. So this trial did not talk about the age at all. That's my input.
Thank you, Dr. Sana.
My name is Dr. Amjad. First of all, thank you for taking me, and well done. It was a very good presentation, a thorough presentation by Dr. Rabia. Dr. Huma and Dr. Sana has summarized it well. I just want to add one significant point to it. Yes, it was a landmark trial in its own time in 2014, but things have moved on. And one thing that we regularly do, all our breast surgeons, we regularly do in our practice, and that is to how do assess axilla pre-operatively. And that is by doing an ultrasound scan. And not all these patients has had an ultrasound scan to assess the volume of the disease, because when we talk about, if you get a 1 or 2 positive lymph nodes in the sentinel node biopsy, the thing that will determine, along with the biology, as to what is the risk of recurrence is how much volume of disease is left in the axilla. So if you just leave it to just clinical examination and palpable or not palpable, you won't properly assess and you won't be able to predict which patients will have more recurrence. So only, I think, part of a few patients had ultrasound scan. That's one point. And as the axillary lymph node dissection group showed, that 33% of the patients had residual disease, and the conclusion, the interpretation of a positive lymph nodes is exactly the same, that if you've got a positive node, you're more likely to have residual disease in the axilla. So if the ultrasound scan was included, maybe that would change the scenario, because essentially what we're saying is the lower the volume of disease in the axilla, the better the outcome and the less recurrence rate of the disease. So if we add to it ultrasound, you add to it tumor biology, you add to it all these different things that we've talked about, then I think the results could be different. The other thing is that we talked about the IBCSG 2301 trial, which compares the outcome between micrometastasis and the macro. It deals with micrometastasis. So that trial has established that you can label micrometastasis in the lymph node as negative axilla, and they do not require any further treatment. But if you go through the data table, we have lymph nodes with macrometastasis which are included, which is fine, but you have a lot of patients with micrometastasis which are included, and you even have patients with isolated tumor cells which are included in the data and in the analysis. So having said that, it's only because things have moved on. It's only because we know a lot more than we did back in 2014. So it's not just dashing the trial. It was a good trial. It was a landmark study. It gave another option in addition to axillary lymph node dissection. But now we have more information as to how to manage axilla, and perhaps we could do it in a better way. As I said, our situation is different, our resources are different, our population, our patient base is different. We have more T3, T4 disease, we have more advanced disease. So maybe we could do some form of variation of the trial which is more suited to us. Thank you.
Thank you very much. Dr. Asad, do you have any comments?
Yeah, sure. Assalamu alaikum. First, I would like to congratulate SOS-PK and the organizing committee for organizing this event. I think creation of this committee itself is a big thing. So congratulations to the society. We should have monthly journal clubs. That's an important thing. That's part of the training for junior doctors. And selecting papers, I think we can all contribute. We can all see if we can find out some important landmark papers for discussion in this journal club. Coming back to the paper, I believe this to be a landmark and practice-changing paper of its time. It was published in 2014 in Lancet, and at that time, we just had Z11 results from US, and for early breast cancer, the management of axilla was changing. The question was for early breast cancer patients where they have little disease in their axilla on their sentinel lymph node biopsy, whether those patients should have sentinel lymph node biopsy followed by axillary dissection or not. But then AMAROS trial came out in 2014, and it gave a different perspective that in addition to surgery or alternative to surgery, there is another alternative. Yes, there is so much we can talk about the critical analysis of the paper itself. We have already heard these comments. There are quite a few limitations. It only can be applied to a limited population of breast cancer patients, especially in our country, where we usually see extensive and advanced breast cancer. Its application is limited. But we still have to think beyond that. We have to think about those patients which are covered by this paper, for example, T1 and T2 disease, and where the axilla is clinically as well as radiologically negative. Except that there is criticism of that about 40% people did not have axillary ultrasound scan. However, we can evolve our practices, and we can see that if we are doing axillary ultrasound for all our patients, and they do not have radiologically suspicious lymph nodes, as well as their lymph nodes are not palpable, then perhaps there is some role of axillary radiotherapy when they have maybe 1 or 2 positive lymph nodes. So I think we should be considering this, obviously with a pinch of salt, that if we have early breast cancer patients, this paper again does not comment about their biology, receptor status, their HER2 status. However, it would be logical that if we consider that early breast cancer lymph node negative or only having sentinel positive with 1 or 2 nodes, and if they have luminal A or B cancers, then maybe we should be considering them. And having our own network would be helpful, that we could share our data from various centers within Pakistan. So I think this is an important paper, and instead of just rejecting it, we should be thinking that maybe in a limited number of patients where it's the indicated patients that they have looked at, we can apply its results as well. Thank you.
Thank you very much. I think the questions raised about the biology are very important, and not all T1, T2 cancers be treated the same way. Now, I would like to pose this question to our faculty, and I'll give you some different scenarios based on the paper. If there is a 30-year-old female who's got T2 triple negative breast cancer, localized, ultrasound negative, positive sentinel node biopsy, how would you manage this? Obviously, management of the axilla.
So if
Right.
you want me to start.
From my point of view, Dr. Huma.
No, you go ahead. That's fine.
So from my point of view, a 30-year-old with a triple negative breast cancer is definitely at a higher risk of recurrence, provided that the number of years that she has to live and the tumor biology itself. In her scenario, I would definitely go for a axillary clearance rather than radiation. subject to what we are doing with the breast. Are we conserving the breast or doing a mastectomy? That is the question. So if we are in either ways, I would prefer to do a clearance on her. Also, another thing that I would like to know from the pathologist at the time of frozen section is how big is the tumor deposit in the sentinel node? Is it just 2 millimeters, more than 2 millimeters? Are we classifying it as micrometastatic or macrometastatic, right? So we need to have that information, but for a clear-cut triple negative in a young female with a macrometastatic deposit in the axilla, I would opt for a clearance rather than a radiation.
I would, it will depend for me, it will depend on like as you said, whether it's a macro or a micro. So that's a definite. And the number of nodes, if we are following the Z11, as you know, the 2+ is like, if it's 3 or more, we would dissect. If there is an extranodal spread, or if there is per-operatively, it seems that the tumor burden is more, then I would definitely, but for 1 or 2 nodes, small micromets, I would still not dissect the axilla in such a patient. And I would go for, if it's a BCT, she will get some radiation anyway, and we can always give radiation to the supraclav and the apex.
Right. I think if we comparing or if we keep in mind the two scenarios, so on one hand, we're talking about auxiliary radiotherapy not being enough if you have 1 or 2 positive nodes. And on the other hand, we are and in the time of Z11, which is saying that you don't need to do anything. So, I mean, there is a big gap, a bridge. So either auxiliary node clearance or nothing. I mean, radiotherapy, we all know, definitely helps. So it will be more helpful than doing nothing. So if Z11 is advocating that you can leave 1 or 2 lymph nodes completely alone with almost comparable outcomes, then we can make a case that at least giving radiotherapy will not make that outcome worse. So you either don't believe in Z11 trial and you think that axillary lymph node dissection is still the standard treatment, and then you compare axillary lymph node dissection with radiotherapy, then that makes sense. But if we are considering Z11 to be authentic and that we can rely on it, which says 1 or 2 lymph nodes, don't do anything, then radiotherapy has to be better than that. My personal practice is that I think along with tumor biology, it is to do with when we get 1 or 2 positive lymph nodes is what is the likelihood and what is the estimated residual disease in the axilla. So I go with the pre-op imaging. So if my pre-op imaging, ultrasound, and in some cases, if I need a CT scan, if they say that they're all normal looking nodes, so even if there is 1 or 2 positive nodes, that is low volume disease. So if in that situation, if preclinical assessment in my patient is negative and I get a positive node, then I go for auxiliary radiotherapy. And obviously, if there is positive nodes preoperatively, we go for dissection. But I would go with radiotherapy. I wouldn't subject the patient to auxiliary node clearance if there is just 1 or 2 positive nodes with a negative looking axilla on preoperative investigations. Thank you.
I would have a different stance. I would offer auxiliary dissection to this patient. Being very young, 30-year-old, bad biology, triple negative disease, and knowing the fact that Z11 criteria does allow for 1 or 2 positive lymph nodes to omit auxiliary dissection. But then we have to know that within that Z11 paper, around or more than 90% of patients were ER positive patients. So they had wrongly distributed data. Although we, in our setup, we also apply Z11 criteria to our patients, early breast cancer patients. However, for triple negative in young women, I'm always extra careful, especially for a 30-year-old. I would be doing auxiliary dissection. If she was 60 or 65, I might omit her auxiliary dissection.
Thank you. Dr. Huma.
I think we have to remember that it's like getting the gross disease out and obvious disease out, because overdoing will probably not really change her survival. The other thing is that, as like Dr. Amjad said, that this is only in the scenario when we have actually absolutely clinically negative axilla, which is clinically and radiologically, that you go for a sentinel anyway. So if on that, no matter what is the sort of, even if it's a triple negative, if there's no other palpable abnormal feeling node there and only one node or two with a micro or, small met, it's not going to change anything, and it will only basically, and she's going to get radiation anyway because it's a BCT. Yes, my approach might be a bit different when you're talking about a mastectomy versus BCT. Then we can basically further think about it, like in such a patient, because the whole criteria would then change. One or two nodes. Do we want to know more? How many? Do we want to irradiate the chest wall or not? So my decision whether I would go for a mastectomy versus a BCT might be different only in a mastectomy versus BCT scenario. That's just the comment.
Thank you, Dr. Ma. I think I'll just, to summarize, there are different rationale for going for radiation therapy or going for dissection or just leaving it alone. And I guess it's important to raise this point that whatever rationale we use, it is very important. I mean, we have an audience of our trainee doctors as well as surgical oncologists. That it's very important to maintain a record of these decisions and then follow the outcomes so that we can actually look at if our decisions were all right. Sorry about this. I'll up the ante a bit. So if we have a 65-year-old lady who is ER positive, HER2 negative, 4-centimeter tumor, unilateral breast cancer, she opts for mastectomy. And on sentinel node biopsy, she has 2 nodes, each have 3-millimeter deposits with no extracapsular extension. So 65, 4-centimeter tumor, ER positive, HER2 negative. We're doing a mastectomy, and there are 2 positive sentinel nodes with 3-millimeter each deposit and no extracapsular extension. What would your axillary management be?
What was the size of the tumor again? Sorry.
4 centimeters.
I think I would basically, in such a patient, she's 65, if she's in good health. Yes. We have to decide about the radiation to the chest wall. So I would probably go for it. And I would possibly dissect the axilla to see whether she needs that or not. Because if it's only 1 or 2 nodes, and then maybe later on hormonal therapy should suffice. But if she has more extensive disease, even if microscopic, then it will be better for her to have radiation to the chest wall. And just from that point of view, I'd do that.
Dr. Asad?
Yeah, as she's having mastectomy, she would, again, Z11 criteria won't be applicable to her. So having even 1 positive lymph node would mean that we are supposed to do axillary dissection in her. But it's a tricky one that the cancer itself was only T2, 4 centimeter. And if she was to have breast conservation with all the rest of criteria, you could easily apply that 11 criteria and then maybe preserve the axilla. So it's something that you can discuss with this patient beforehand in consent process, that you are doing intraoperative lymph node assessment. So you can talk to the patient and say that if you, what would be more important to the patient. But otherwise, I would be in favor of axillary dissection in this patient.
Okay, so as per the clinical scenario, she likely is not a candidate for radiation therapy, and I second Dr. Homa and Dr. Asad Parvez. Not doing an axillary dissection would be another treatment regime while she's undergoing surgery for sure. I would prefer doing an axillary clearance on her, because at 65 in our part of the world, we don't expect our 65-year-olds to lift weights or do heavy exercises or indulge in any kind of heavy activity. So a 65-year-old with a life expectancy of perhaps more than 10 years, I would opt for an axillary clearance rather than putting her through another modality of treatment, that is radiation. And radiation itself, we know, can have some level of effect on the lungs as well as underlying cardiac tissue in women who are frail and have less body fat. So I would opt for an axillary clearance.
It seems like I'm the odd one out here. Now, Dr. Asad pointed out that we cannot apply Z11 because she's got mastectomy. We have to, when we talk about the different aspects of trials, we have to see what are the limitations and what are the pluses and the minuses. I think that's a limitation and a minus of Z11 rather than a plus point. So perhaps we shouldn't adhere to it so strongly, because if you think about it, if you have a mastectomy, the patient's local recurrence rate is even lower than if you do breast conservation surgery. So if you think about that 1 or 2 positive nodes, macrometastases, in someone who has breast conservation, they are okay. If they don't get any further treatment, then what's the logic? Or I'm just thinking, perhaps a mastectomy patient doesn't have any other risk factors of having an increased risk of local recurrence. If a breast conservation patient should be okay with it. So that's one point. The second point is that, again, I'm going back to my pre-operative clinical assessment of the patient. If I'm doing sentinel node on this 65-year-old patient, then that means that radiologically and clinically she has a negative axilla, and perhaps she has 2, maybe 3 lymph nodes, and perhaps we've taken out 2 nodes and 1 is left behind, and we don't know whether it's micromet or macromet. So the disease burden is actually low. And the third point is that if we've subjected her to a general anesthesia and a procedure once, then the other option is, should we go for another GA, another procedure, or should we go for radiotherapy? Which one would have more implications in terms of the aftercare? So as the AMAROS said, your clearance has about 28% risk of lymphedema and significant range of restriction of range of movement compared to your AMAROS with almost similar rate of recurrence and overall survival. And from a patient tolerability point of view, I think if a patient can have 2 general anesthetic procedures, one after another, is well enough to have radiotherapy. The only reason why I would subject this patient to a further clearance is that if I don't have facilities for radiotherapy. Otherwise, I think radiotherapy would be, number one, kinder to her going through the treatment. And I think if you look at overall survival, life expectancy in Pakistan, we have to be realistic. We can't just pull out a number out of thin air. Life expectancy in Pakistan is in high 60s. She's 65, and she has only 2 positive nodes. So as I said, perhaps I'm the odd one out here, but I'm again inclining more towards radiotherapy, simply for the fact that it will be kinder to the patient, and perhaps the overall survival would be the same as well.
Can I please add a comment? I would probably have 2. There are 2 limbs. Remember that we are not doing the axillary clearance to avoid radiation to the axilla. I'm doing axillary clearance to see whether she needs chest wall and supraclav radiation. That's the main thing that I'm looking at, rather than axillary radiotherapy per se. And we all know that for mastectomy, the criteria is 4 or more nodes. So you need to know when you need to give XRT or not, and not to increase the morbidity. As you said, in BCT, there's always some there is some radiation which goes to the axilla anyway. But in mastectomy, that's the main question. So if a good quality life person, then yes. But if it's like somebody who's older and not very good quality life, then yes, you can just sort of do nothing and just, but have to add radiation there, which has its own morbidity.
Just one personal question and just getting Dr. Huma's opinion. So on one option is if we do axillary clearance, and then if there is a fourth node or a fifth node, then do chest wall radiation. So on one arm, we have radiotherapy as well as surgery. How about we give her, because there is a conflict, some radiation oncologists that I know would even radiate N1 disease axillary patient as well. But anyway, how about giving her chest wall radiotherapy and axillary radiotherapy? If she's going through radiotherapy, if we radiate the chest wall along with the axilla, how would that sound compared to putting her through clearance and then possibly through chest wall radiation as well? What are your thoughts?
My thoughts are, as I said, one thing which is extremely important is her quality of life. So we only have 6% of population above the age of 60. So whoever survives that, they are all tough cookies. So if they are, you never know, she may live up to another 10 years or no. So it will all depend on her quality of life, whether she can go for and stand for radiation therapy and stuff like that. So if, so all these and the availability, but personally, like given in my scenario where we have the radiation facility available, then yes, if she is like bad quality of life, I would only go for radiation. If she's good quality of life, I'd go for clearance to know whether she needs supraclav and chest wall radiation to prevent long-term sort of good control and to reduce the metastases or overall survival.
So I would just like to add one point, and obviously it's a discussion. If we go by the book, and keeping all the factors aside, just if we all know that a sentinel node positive in of life and the life expectancy, and there are various calculators driven from Western literature available that can predict the life expectancy of women depending upon their age and comorbidities and physical status. So life expectancy is one thing which can be somewhat predicted. And we can say that if our patient has a life expectancy of less than 10 years, and there's a low chance that she may even die because of an axillary recurrence if she ever has one. So talking about being kinder to the patients, I feel that a woman, an elderly woman, a 65 above, who has to come to the hospital daily to get her radiation done for 15 days or for 21 days, is not a 15-minute job. It's, she has to come, wake up in the morning, come to the hospital, have an acquaintance, stay there for a couple of hours, and then go back to her house. Can be quite tiring, and radiation itself can cause a lot of fatigue in women. So we've had instances in elderly women, particularly those who were living alone, where she was a candidate for breast conservation but opted for a mastectomy in order to avoid the excess trips to the hospital for radiation. So it's always we need to see the patient as a whole, her circumstances, her physical status, her tumor, her support system, and many things put together. As a clinician, we have to decide whether this lady should or undergo a clearance, or we can spare it and put her through radiation. So there are many factors that should be taken into account, and the treatment can be tailored accordingly, especially for the elderlies, because that's a totally different group of individuals.
Raza, if you would just raise the age to 70, we would have a lot easier discussion. So, but this is like the 65 to 70 age group is tricky.
That's a bridge, sitting on the bridge.
Yeah, then you have to decide, like, which side, and weigh a lot of things. Yeah.
Because now even the literature is coming up where above 70 can even skip sentinel node biopsy if they are early breast cancer with favorable biology. So there is data coming up supporting the fact that we can skip even sentinels in that group of women. So we need to be, dot the I's and cross the T's before deciding whether we do a clearance versus subject her to radiation? See, Dr. Asad?
Just one simple point that, especially for juniors who are all listening here, that for such patients where obviously two different decisions can be the right decision. So it's not the matter of choosing one right thing versus the other wrong thing. We all know that both options, offering surgery or radiotherapy in this patient, both would be the right option. So it's selecting the better one is the question. And I believe that we should be involving patients in this decision as well. And this can only happen if you spend time right at the time of consent or before in the clinic. So you explain all these pros and cons, the morbidity associated with surgery and the practicalities associated with radiotherapy, the number of sessions they have to visit hospital, especially if they are from far-flung areas and they have to come to a central city for radiotherapy. So they have to contribute to making such decision. And if you come to that decision before before taking them to the operating room, and for example, if you are doing frozen section and you come up with this scenario that you have two positive nodes, and then if you have not talked to patients about this scenario, that whether you are going to do dissection or radiotherapy, then you will have similar sort of thought in your mind. But if you have talked to the patient and given them pros and cons, then you might come to an easier decision. Thank you.
And the cost matters a lot as well in our population. Doing a clearance versus radiation would add up. Doing radiation, I suppose, would be more expensive in certain parts of the country.
Thank you very much. There is a question raised in the chat that, as the paper said, lymphedema is more in the group of surgery. The trial did not limit the axillary dissection to level 2, which is equal oncological outcome with level 3 dissection. If the axillary dissection is limited to level 2, the difference in the outcome of lymphedema, as the trial showed that the radiotherapy arm had decreased incidence of lymphedema. Do you think there would be a difference?
I think it's like, as I said, that they are not really, they told us that in the surgery group, they added radiation therapy to some. But then they did not tell us whether the lymphedema was more in that group or not. So I don't know. It might be that because in some patients, they added radiotherapy to surgery. And we know that either you do surgery or radiotherapy. If you do both, then the incidence of lymphedema is very high.
And in their description of procedure, they have said that they have limited axillary lymph node dissection to level 2. They have not done level 3 clearance in a single patient in this group, as far as I understand from this paper.
No, I think if I put my opinion, I think the question is that what the gentleman is saying is that the surgery was not limited to 2. So there were patients who have had possibly level 3 clearances, and maybe the question that he's asking, if I understand correctly, maybe if we limit the dissection to level 2, bring it down from 3 to 2, would then the lymphedema be comparable to radiotherapy? Because in axillary dissection group, the lymphedema is high compared to radiotherapy. And the hypothesis that he's suggesting, or she's suggesting, is that it's perhaps that we're going to level 3. If we limit the dissection to level 2, would that bring down the lymphedema rate? I think that's how I understand this question. And to answer this, we don't routinely go till level 3. We usually stay below axillary vein. And we only go beyond if there is some palpable suspicious disease. Then we go up above. So it's not like in routinely there was no need, and if there were any cases where they went to level 3, that they were just because of the routine dissection. So in our current day practice, we don't routinely do level 3 clearance unless there is palpable suspicious disease. So I'm not sure if that would bring down the lymphedema rate sufficiently low that it would make it comparable with radiotherapy. And then you can say now the two treatments are more comparable and you can choose either of the one. So I think the lymphedema rate would still be lower with the radiotherapy, if I've understood the question correctly.
I think there was, if you look at the patient population and the treatment offered, like Dr. Asad pointed out, the axillary resection is limited to level 1 and 2. However, the radiation therapy includes all 3 levels as well as part of the supraclav. So if radiating all 3 loads is compared to the section of the axilla at level 1 and 2, then the outcomes do suggest that radiation has increased or decreased risk of lymphedema, as long as this group of patients who receive both surgery and radiation are not confounding this outcome difference. I would ask one last question. In any of the scenarios that we discussed, would HER2 status make a difference? So if this is a HER2 positive patient, would it make a difference to your choice of management to the axilla?
Personally, not hugely, because dissecting axilla beyond what is required is not therapeutic. It has prognostic sort of significance more than anything else. So in BCT, again, I say it again and again, I'm sorry, there's always some radiation which goes there. The other thing is that obviously all the other parameters like the size of the tumor, the patient's age, hormone, whether hormone positive or not, along with being HER2 positive. So all those things will also matter. But if it's like low volume disease, 1 or 2 lymph nodes, nothing else palpable, PCT, you have actually Herceptin, adding Herceptin, it is a bad prognostic thing, but whoever can afford Herceptin, they have a better outcome as per the data. But the problem is that not everybody can afford Herceptin. So again, you have to consider about all that. So multiple factors, individualized. We have to, all the studies, all the guidelines are to guide us, but we have, and in the, we have to basically add up and then decide what's best for the patient, really. As Dr. Asad said, along with the patient's consent.
If I may add, the aim of the surgery is obviously, as we all know, is to remove all the detectable disease. So it doesn't have anything to do with what the receptor status is and what the grade is, because if you flip it and if you look at, say, doing a breast conservation surgery on someone, you don't say that because it's HER2, I need to get 5 millimeter margin, or because it's triple negative, I need to get 3 millimeter margin. The resection margin remains the same, irrespective of the grade of the tumor or the receptor status. So I think the same principle applies. The aim is to get all the disease out, whether from the breast or from the axilla. And practically the receptor status wouldn't matter much in deciding this decision.
Okay, so for now, for tumors that are HER2 positive or triple negative, neoadjuvant chemotherapy is the first line of treatment because it helps us to predict the in vivo response of tumor to systemic treatment and hence improve the survival. So if any of such patients is HER2 positive, now I'm not talking about a 65-year-old who's not physically fit. I'm talking about the majority chunk of the women who are physically fit and can tolerate the chemotherapy and the targeted therapy. I'm just thinking out loud. A woman who's HER2 positive, early breast cancer, receives neoadjuvant systemic treatment, including Herceptin, following which she undergoes surgery and is found to have positive nodes on the sentinel lymph node biopsy, I would prefer to go for an axillary clearance because this means that the tumor did not respond well to her targeted therapy. It means she has a stubborn tumor with a higher chance of recurrence. So I'm thinking on that lines. If a woman HER2 positive received systemic treatment prior to her surgery, still has positive nodes post systemic targeted treatment, definitely merits an axillary dissection. Definitely she would require radiation afterwards as well, but I would do an axillary clearance on her.
Yeah, so that's very important. Like neoadjuvant is a completely different scenario. So even one node positive, you have to go for the dissection. Upfront, 2 centimeter, triple negative, HER2 positive, go for neoadjuvant before you go for surgery, because you can then see the response as well, not just because of like a therapeutic or prognostic advantage, but you also need to see the response. So yeah.
And I would agree with both points.
There's a very interesting point raised that our quality of life and circumstances are different from the circumstances where this trial was offered. And the question that is raised is subjecting patient to a dissection at the age of 65, and then after dissection, whether deciding the patient needs another treatment, for example, radiation therapy. Why not go for radiation and decrease the morbidity of axillary dissection and increase operating time? And as far as lymphedema is concerned, the trial suggests that it did not decrease the quality of life. But in our area, in our population, it may certainly limit the quality of life. What are your comments on this question?
So come to think of it, this woman who underwent an axillary dissection has now 4 or more positive nodes and now merits a radiation. All the more reason she qualified for an axillary dissection rather than leaving gross nodes behind. So dissection was the right answer. I'm glad the surgeon did it.
And the other thing, Raza, you can tell everybody how many linear accelerators do we have in Pakistan?
That was my next point that I was going to ask, because we have to also consider the access to radiation therapy. And obviously the point that the quality of radiation therapy that is being offered in this trial is much different to what a routine radiotherapy appointment for our patients and according to their affordability they get. Also, the time constraints and time to radiation therapy in our population is certainly something that we need to work on. But obviously, that is a question that has its merit, definitely.
If I may add a comment to this, yes, I mean, what we're doing is we're mixing different points and different things, which is slightly, I think, confusing the scenario. The first thing is that if you're talking that you cannot offer someone radiotherapy for 4 or 5 months after surgery, there's no question you have to go for surgery. If you don't have a linear accelerator, if you don't have radiotherapy facility, that's a separate issue. You have to go for axillary node clearance. That's not the question. The question is, in this scenario, would you subject this patient to clearance or radiotherapy? I just want to add one point here, which Dr. Sana commented on, is that if you do axillary dissection in this, and then you get another 2 nodes, so now you have 4 nodes. Now, the thing is that if you have a positive sentinel node, this AMAROS trial also suggested there's 33% chance that you will get more disease if you do axillary clearance. Even if you have negative sentinel node, there is a 3% in best hands, there is a 3 to 4%, 5% false negative axillary sentinel node biopsy, which means that if you have a negative axillary sentinel node biopsy and you do axillary node clearance in 3 to 4% of patients, you will still find some disease. That's not the question. The question is what to do. Is that disease volume large enough And is that significant enough that you need to do further surgery for that or not? And that's what the AMAROS and Z11 is addressing. They're not saying that if you have 2 sentinel node positives in sentinel node, that there won't be any further disease in the axilla. This trial also says 33% patients will have further disease if you subject them to axillary node clearance. The question is what to do with that disease. And from my understanding, that disease is significantly low volume enough because sentinel node did only pick 2, and preoperative assessment said that there was no significant disease. So that's about categorization, quantifying the residual disease, and whether that's low enough that you can either leave it according to Z11 or give radiotherapy and manage it according to AMAROS. I think that's
Dr. Amjad, carry on, please.
Assalamu alaikum, everybody. This is Dr. Chima. I just wanted to congratulate Dr. Raza Syed on organizing such a useful discussion. Also, Rabia, who presented her paper really well. And I think Dr. Homa Majid, Dr. Asad, Dr. Amjad from Peshawar, as Sana Zishan, they all have contributed very well to the discussion. I hope and pray that this activity carries on every month as YSAC has planned it on the platform of SOS-PK. So I must thank Dr. Raza Syed again for taking the trouble. He is in London. He has been working hard for some days and on organizing it. Raza, over to you.
Thank you very much, sir, for this. I think this was an opportunity to bring everyone together, and I'm very humbled and honored for that. We will continue this discussion because there are some questions still raised in the chat. Dr. Amjad, what were you saying? Sorry, we got interrupted.
My point was that when we get 1 or 2 positive nodes after a sentinel node biopsy, that doesn't mean that axilla only has 2 positive nodes. That means that axilla, if you look at the data in this trial, it shows that about 1/3 of those patients will have further nodes. Because if we are sure that axilla does not have any further residual disease, then there's no point of further treatment. And that's what we do with axillary clearance. So if you have pre-operatively positive axilla and you clear it, so then you're satisfied that you haven't left any residual disease in the axilla. So that's why you don't treat it further. The main reason why we treat patients who have 1 or 2 positive sentinel node is that we strongly suspect that there is some residual disease still left in the axilla. And the question then is that volume large enough that we need to do clearance for it, or should we do radiotherapy? And now Z11 has thrown in another aspect to it in saying that if it's just 2, the likelihood is that it's such a low volume disease that you can even leave it completely alone and not do anything with it, and patient would still have comparable survival. So the point that I want to throw in is that there is about 33-34% chance of every positive node patient to have further residual disease in the axilla. So if you clear it, you will find further disease.
Thank you very much. There is just one actually very interesting question raised, and that goes beyond the initial treatment and addresses the issue of salvage of recurrences following axillary radiation therapy. So can there still be need for axillary dissection as a second surgery post-radiation if we opt radiation over dissection at the first surgery? Sorry to say, because we've almost gone 1.5 hours, this will be the last question, although it's a very interesting discussion and questions keep coming, but we will limit our discussion after that.
Yes, so I think we can. As soon as if you have a local recurrence, that is what I assume it is. If it's a regional recurrence, and you have now a lymph node in the axilla, which is proven to be local recurrence on either cytopathology or histopathology, then you have to do metastatic workup first. If there is no metastatic disease, then yes, you can go and excise it, because you should not really give further radiation to that. That is going to make things very difficult. I'm always for excise first and then radiation, rather than radiation and then wait for excision, because it makes things very messy. But we must rule out metastatic disease, because there's no point going for axilla if there's disease somewhere else.
So once the tissues are radiated, and be it any part of the body, there is extensive fibrosis, and the tissue actually becomes like cemented, and you're cutting through a cement block. So just imagine an axilla that has been radiated and now has a recurrence, and now one plans to excise it is going to be a nightmare for the surgeon, really. Because not just the extent of fibrosis, it's the adherence to the vitals, to the axillary vein and the nerves. And then attempting to excise that recurrence in a radiated axilla is probably perhaps going to be the most difficult thing. I've never done that before. I don't know whether Dr. Huma, Dr. Asad has any experience in doing that. But I presume it's going to be a very difficult scenario for a surgeon.
It is very difficult, and beware, all the trainees, don't get too excited in such a scenario to see a thin patient. It is a nightmare in a thin patient, because there's no tissue and everything is so adherent. You go in very happy and all you see is like just tissue wrapped around your vessels. So a fatty patient is probably a little bit, they do better in such a situation. But yes, you're right, it's very difficult.
I agree with both Dr. Huma and Dr. Zishan or Dr. Sana on this. The thing is that if you are radiating an axilla, you are saying that you've cleared most of the disease surgically. If you believe that there is some residual disease in the axilla that needs macroscopic disease and disease that you can see on imaging, then you shouldn't be radiating it first. Always do surgery first, followed by radiotherapy. So if you are radiating, that means you're done with surgery already. So then that would be a case of locoregional recurrence. And if you're talking about locoregional recurrence, then you can make a case for axillary nodal dissection. But if after first surgery, you believe that there is significant disease left in the axilla, you shouldn't be radiating. It should be surgery first, followed by radiotherapy.
I agree with all the panelists that I think the question is about if the patient has upfront surgery and their lymph node was positive and they were opted for radiotherapy to axilla, then I wouldn't go back and do axillary clearance in routine. However, if there is axillary recurrence later on, then depending on staging investigations and whether it is operable and resectable, only then I will go in and remove those lymph nodes.
Thank you very much. I must thank all the faculty for their time and so much wisdom that they have given us. To Dr. Rabia, who's done a wonderful presentation, and this has set a very high bar for our subsequent presentations. Thank you, Dr. Rabia. And to all our participants as well. We will definitely hold these sessions on a monthly basis. And in fact, our next journal club will be held on 26th of March, and we will make the announcement hopefully in the next few days as well. I would ask Dr. On to kindly make some comments. He's the General Secretary of the Society of Surgical Oncology of Pakistan. And we are very, he's been a source of help and a great support in organizing all these activities. Dr. On.
Thank you very much, Dr. Raza, for giving me this opportunity. I would like to congratulate Rabia on presenting a wonderful, journal club article and setting a trend for the subsequent speakers. And I would like to thank all the faculty members for putting in a wonderful effort. So what I wanted to announce was that we would be having regular academic sessions, and we would shortly give you a calendar for that, and we will announce it on our websites, and we like to have give you schedules for like 2 to 3 months in future, and we will inshallah hold very regular meetings, and we want to what we want is we want to educate our people, and we would want to improve the standard of surgical oncology, and inshallah we will be holding all these meetings for the betterment, for the education of our people very regularly. And I hope Dr. Raza and everyone would support us in holding these. And I thank everyone for a wonderful participation.
Thank you very much, Dr. On. I would like Professor Arshad Chima, who's actually the source of all energy within our society and a lot of support for us. He has started this effort on his own a long time back, and we've come actually quite far. Sir, your closing remarks, please.
I think it was an extremely useful discussion. All the panelists, apart from the presenter, Dr. Rabia, they all did very well. And I think this is a very good beginning, and we should keep it up. I think we have come a long way from 2008 when we started. We used to have Skype meetings from abroad, and then we would sometimes use a Google Meet, but I think Zoom has worked really well. And we are going to have, inshallah, in very useful discussions, as On was saying, in the days and weeks to come. So thanks everybody for this this great effort, Raza, especially you. Okay, Khuda Hafiz.
Thank you very much, sir. With that, we conclude our session. I once again thanks everyone, especially our faculty, Dr. Rabia and Professor Chima, Dr. On, and all the participants. Without you, this activity is just not worth anything. Thank you very much, and we hope you will join us in our next academic session and activity. Thank you. Allah Hafiz.